welcome back to Preserve Health Talks. We're pleased to have as our guest this morning Lois Cassle, ARNP, for her second round here on our show on hormone replacement therapy. And today, Lois Cassle from Elite Health and Wellness, expert on hormone replacement therapy, talked about estrogen and progesterone replacement last time, and a little bit about testosterone replacement therapy in women. Now we're going to talk about testosterone replacement in men. Good morning.
Good morning.
So my first question to you is, what exactly is testosterone replacement therapy? And that's hard to say, so we're just going to call it TRT for the rest of the show. So what is TRT, and what options are there for administering testosterone?
So testosterone replacement therapy, particularly in men, men peak in their testosterone from the ages of 18 to 25. And by the time a man is 30, they start losing negligible amounts of testosterone every single year. This largely goes unnoticed until their levels start decreasing below, for some men it's 600, for some men it's not until they get to 300. But so what we do is, after checking their levels and seeing if they in fact need it, then we replace it or supplement it with either injections, topical, or pellets. Those are the three. Actually, they're all bioidentical, but different.
And how do you decide which formulation to use?
So the injectable testosterone, a man has to, for the most part, do himself, and it's an intramuscular injection, and they have to do it 1 to 2, even sometimes 3 times a week, depending upon their situation. The topical is something that they have to do twice a day, and the pellets are something they do twice a year. So these options are presented to the patient, and it is basically up to them the way they want to do it.
And everybody wants to know this question. Cost. Is one formulation more costly than the next over, let's say, over a year period of time? If I go with testosterone implants versus a daily gel, which is only partially covered by insurance usually, can you give us an idea of what this might cost? And
again, that depends. Are they clinically low testosterone, hypogonadism? So the range on the labs is, depending on the lab, 200 up to 1200. If in fact they are less than 200, insurance would cover the injectable for them. It would not cover the topical, and it would not cover the pellets. So that would be the least costly to the patient, but also the most uncomfortable. But the pellets and compounded creams are not covered by insurance at all. The pellets run approximately $1,500 a year for men to do. So that breaks down to about $125 a month, which is pretty similar to what the topical would cost.
Got it.
So what are the most common symptoms of low testosterone that you see in your patients?
So for men, that would be low libido, erectile dysfunction, loss of muscle mass, depression, irritability. And those are just the outward signs that you see. But what is going on inside the body with low testosterone that you might not see is the chronic diseases of aging that start to increase as the testosterone levels go down.
So not just men, but women can also benefit from testosterone replacement therapy.
Yes, women also around the age of 30 start losing testosterone, and it is equally important for women to be on testosterone as it is men.
And I would imagine, because I know this to be true, so I don't have to actually imagine it, that there are cardiovascular benefits in replacing testosterone?
Yes, there are.
Can you focus on that just a little bit?
So the biggest cardiovascular benefit in using testosterone is the aromatase, because testosterone converts to estradiol in men. And men have no other way to get estradiol other than through aromatase. They don't have ovaries, and that's the only other place in the world it's made. So estradiol is cardioprotective, and cancer protective and bone protective. So these are the other benefits for men.
So the audience is out here.
You know what else I forgot?
Oh, go ahead.
It also lowers lipid levels.
Yeah, it does.
And that is really important. They have more muscle mass, so it gives them better metabolic health also.
Right, it lowers specifically LDL cholesterol,
Yes.
the low density lipoprotein.
Yes, and we see that after about a year of treatment in checking lipid levels.
And your HDL may actually go up because of the aromatase
Yes.
conversion, correct?
Yes, correct.
Okay, good. So what does the evaluation process look like for someone considering testosterone therapy? We send a lot of patients for testosterone therapy to you.
Mm-hmm.
We do some replacement in the office ourselves. And my patients always say, why do you need to run tests on me? I didn't realize there was an evaluation process other than just checking to see if I have a low testosterone level. So what evaluation process do you use in your clinic for testosterone prior to testosterone replacement therapy, TRT?
So at our consultation appointment, the patient, after we get a very comprehensive medical history, we give them a very comprehensive lab panel, because not a lot of the symptoms of low testosterone could be other things, and we don't just give out testosterone because somebody thinks that's what they want. We want to make sure that, first of all, that they don't have a pituitary issue going on, or they don't have a thyroid issue going on. A lot of the thyroid symptoms mimic the low testosterone symptoms. So, but before you can correct anything, you have to be optimized on your hormones.
And are you just checking blood work, or are you actually getting an MRI with looking at the pituitary gland?
No, you do not routinely do that unless the blood work comes back indicating that that could be necessary.
So how do you monitor the testosterone levels? How often, once you start a patient on the replacement, are you checking these levels, and what do you look for?
So that depends on the delivery. I like to check testosterone levels at their peak, where that is quite the opposite of where most people check them. Most people like to check them at the trough because the numbers look prettier. I like
Right.
to see it where it is. So if they're on pellets, the peak of a pellet is between a month and 6 weeks out. So we do post-pellet blood work on that. And what we're looking at is not only what their testosterone level rose to, but we're checking for side effects. We're checking what their estradiol level went to. We're checking what their hemoglobin and hematocrit went to. This is another side effect of testosterone replacement, that they could get erythrocytosis, which is an elevation in the hemoglobin and hematocrit. And if that happens, we have to send them for therapeutic phlebotomy, where they donate blood and correct that issue.
So they make good blood donors.
Well, they can't always use that blood, so we give them an order. So sometimes they have to waste the blood. If the hematocrit is too high, the one blood will waste it. They won't use it
And the reason being?
because the hematocrit's too high, and it's not a great specimen for donation.
Okay.
It's not always a good specimen for donation.
Okay. All right. So once someone begins testosterone replacement therapy, how soon do they typically notice improvements, and what changes should they expect to see?
So with pellets, it takes at least 2 weeks, 2 to 4 weeks, because it takes a minute for your body to start to wrap capillaries around the pellets and for them to get into the bloodstream and to get a therapeutic level. At 6 weeks, that's why we check the labs there. But about 2 weeks is when they start to first notice it's a slow and gradual thing, that their energy might improve, their sleep might improve, their libido might improve. It takes longer than that to start to see improvements in muscle tone. But with injectables, they'll see it peaks in 2 to 3 days, but it's a cumulative effect over about a month before they start to really feel different also.
What are some potential side effects or adverse reactions that patients should look out for once they start testosterone replacement therapy?
So they differ for men and women. For men, adverse effects as far as what they feel, there really aren't very many. There aren't any. But we watch for the side effects in their blood, like we spoke about with the increased hemoglobin and hematocrit, the increased estrogen levels, and we check a PSA also. Every single time I do blood on a man on testosterone, I check a PSA. Because if we catch a rise, we want to make sure that he hasn't developed something while on testosterone.
Right, but let's make a statement here that I want the audience to know, that testosterone doesn't cause prostate cancer, but it can feed into a cancer that is already existing. And that's a big myth and
Yes.
misconception, that testosterone actually
Absolutely.
causes prostate cancer. It does not,
When
correct?
quite to the opposite, it's prostate protective, which is why you don't see prostate cancer very often in young men who have higher levels of testosterone. But it is a big myth. If there was one thing that I wish everybody could know, is that it does not cause prostate cancer any more than your own body's natural testosterone would cause you cancer. If this were true, teenagers would be rampant in prostate cancer.
Right.
Okay. So are there any other myths or misconceptions about TRT that the audience might want to know?
Well, that is the biggest one. The other one is, are you too old to do it? And my answer is no. You're not ever too old to do testosterone replacement. It makes you feel better. The older you are, in fact, the more you need it.
So for someone who's hesitant about starting testosterone replacement therapy, what's one thing that you wish they understood?
It was just that it is
Yeah.
never going to give them cancer.
Good.
Okay. Well, our time's up again, and it always goes by so quickly, right?
Yes, it does.
Yeah, it's a pleasure having you here again. Lois Cassle, ARMP, has her own practice, Elite Health and Wellness.
772-777-8233.
Elite Health and Wellness, thank you so much for coming back, and we'll have you here again.
I look forward to
So
it.
we've
Thank
got
you.
a lot more questions for you,
Thank you.
and thank you.